నవీన్ ఏడి నవీన్ మోడరేటర్ ఏమో Hello, Santosh.
Hello, sir.
Good morning, Santosh.
Good morning, sir.
Start చేసేసి class.
Start చేయండి, sir. Good morning to all my seniors. I'm Dr. Santosh. I'm a primary DNB resident in Care Hospital, Visakhapatnam. Today I'm going to talk about physiological changes in pregnancy. Scope of my presentation is like this: introduction, physiological changes in various systems, anesthesia implications, summary, and my references. Introduction. Pregnancy produces profound physiological changes adapted to stress that become more significant as pregnancy progresses. These changes can be due to hormonal alterations, mechanical effect of gravity uterus, increased oxygen and metabolic requirement of the individual, hemodynamical alterations. These changes have significant impact on anesthetic pharmacology and physiology, resulting in unique anesthesia management required during pregnancy. Coming to the various systems that are affected by the pregnancy, the first and the most important system that got affected during the course of pregnancy is endocrine system. So I'm going to discuss about endocrine system first. As I already mentioned, first system to be involved is the endocrine system. In this, the placental secretion of estrogen and progesterone plays major role in the physiological changes of during the pregnancy course. Along with that, thyroid gland size increases and concentrations of T3, T4, and TSH levels may rise due to fetal secretion of thyroxine during the pregnancy. And placental secretion of progesterone and estrogen have various effects on the physiology of the pregnant woman. Basically, main importantly, progesterone plays several roles, which I would like to enumerate now. It usually stimulates the lipoprotein lipase, which increases the fat deposition during the pregnancy, and it is responsible for weight gain during the pregnancy. And the progesterone interferes with the carbohydrate metabolism that results in the glucose intolerance and increased serum glucose levels during the pregnancy. And progesterone may cause increased secretion of aldosterone, which results in sodium and water retention, and which further results in hemodilution during the pregnancy and increased blood volume during the pregnancy. And progesterone increases the blood supply to the skin, which further increases the basal temperature of the pregnant lady. Pregnancy leads to hypercoagulability state due to increased levels of plasma clotting factors like 7, 8, 10, 11, and only factor 9 values will be reduced during the pregnancy, and increased fibrinogen and FTPs. It also results in decreased fibrinolytic activity and decreased levels of plasminogen activity. It also results in decreased antithrombin 3, probably a protective adaptation to lessen the risk associated with the acute hemorrhagic status that occurs during the delivery. Because of all these increased factors, the bleeding during the pregnancy in the postpartum period will be reduced, and it is useful during the postpartum period. Increased risk of thromboembolic diseases may be seen during the pregnancy because of the increased clotting factors, and DVT is the most common most common thromboembolic disease, which can be seen during pregnancy because of prolonged bedridden state and all these increased coagulation factors. And while coming to the blood volume, it increases up to 90 ml per kg during the pregnancy and increases to the maximum of 1000 to 1500 ml at term, which results in increased plasma volume of up to 45% and increased RBC mass up to 30%, due to which there is a dilutional anemia and there is a decrease in blood viscosity. Dilutional anemia further leads to maternal fetal exchange of respiratory gases, nutrients, and metabolites, whereas decreased blood viscosity might decrease the impact of maternal blood loss at delivery. Cardiovascular system. There are several anatomical and physiological changes during the pregnancy. First, I'll enumerate the anatomical changes. Anatomical changes, apex of the heart usually shifts above and left due to the press exerted by the gravity uterus on the diaphragm. So diaphragm level rises, which results in the shift of apex from its normal position to the above and left, and the size of the heart increases to pump the increased volume of blood. And during the pregnancy, heart sounds. There will be accentuation of S1 and splitting of mitral and tricuspid components, and there is an audible third and fourth heart sounds, which are considered as normal normal during the pregnancy period. And while coming to the murmurs, there is a systolic murmur which can be audible along the left sternal border, and it is considered as normal during the pregnancy. The stretch force of muscle contraction increases, which further uh, result in hypertrophy of the heart. Blood pressure and systemic vascular resistance (BP) increases in the first trimester and reaches the baseline at the term by the term of the pregnancy. Systemic vascular resistance decreases due to the vasodilation caused by progesterone, estrogen, and prostacyclin. Hemodynamic changes that are seen during pregnancy are cardiac output. Usually, cardiac output increases more than 50% during the pregnancy. There is no change in the third trimester, but the first and second trimester changes the cardiac output. Well, coming to the heart rate also increases during the first trimester of the pregnancy. Stroke volume increases in first and second trimester of the pregnancy. Ejection fraction increases. Mild diastolic dysfunction may be seen during the pregnancy. Uterine blood flow increases up to 900 ml per minute during the pregnancy at term. Blood flow to the skin increases, because of which the temperature, basic vessel body temperature may rise. Next, coming to the iotocaval compression. This is basically mechanical compression due to the gravity uterus on aorta and inferior vena cava. Blood return through the collateral circulation. As there is a pressure on the inferior vena cava, it might collapse. So, physiological adaptation to the pressure leads to increase in collateral circulation through epidural veins, because of which the collateral circulation and congestion over the epidural veins increases, and the pressure on aorta may result in lower BP in lower limbs. Supine hypertension syndrome. This is basically due to the pressure of gravity uterus on inferior vena cava and aorta. There will be a marked decrease in blood pressure, which will be compensated by the peripheral sympathetic activity. During spinal anesthesia and epidural anesthesia, the compensation might be lost because of the uh, loss of sympathetic tone in the anesthesia. These are the various parameters that changes in the pregnancy. Blood volume may rise up to 30%. Blood plasma volume may rise up to 45%. Cardiac output may rise up to 30 to 50%. Stroke volume may rise up to 20 to 50% during pregnancy. Heart rate rises by 15 to 25%. Peripheral vascular resistance might decrease, and central venous pressure (CVP) mostly remains the same. And various investigations and their findings during the pregnancy are enumerated as below. Chest radiograph. Apparently, there is a cardiomegaly. Enlarged left atrium may be seen during the lateral view. Increased vascular markings and straightening of left side of the heart border may be seen. Postpartum pleural effusion may be seen in some cases. ECG. Right axis deviation will be there, and right bundle block appearance might be seen in some cases. ST segment depression on left precordial leads may be seen. QAS in lead 3, T wave inversion in leads 3, V2 and V3. Rotation of 15 degrees axis may be seen in some cases. 2D echo, trivial tricuspid regurgitation, pulmonary regurgitation may be seen. Aortic valve remains unchanged. There is no effect of pregnancy on aortic valve, whereas trivial tricuspid regurgitation, pulmonary regurgitation may be seen, mitral regurgitation may be seen. A slight amount of pleural effusion may be seen during the postpartum period. Respiratory system. As I already mentioned, oxygen demand and metabolic demand increases during the pregnancy. It results in increased ventilation. That means increased minute ventilation will be seen during the pregnancy. And due to the secretion of a hormone relaxin by the placenta, there is a marked relaxation of all the ligaments of chest and pelvic cavity will be there, because of which the size of the chest cavity increases anteroposteriorly and laterally to accommodate more volume of air during the inspiration and expiration. There is a marked nasal congestion will be there because of the congestion of vessels in upper respiratory tract. So there are continuous nasal congestion and blockage of nose might be seen during the pregnancy. CO2 response curve shifts towards the left due to increased sensitivity of chemosensitivity of the receptors. And during pregnancy, there is a decreased alveolar dead space, which results in decreased FRC, functional residual capacity, and which might further leads to atelectasis collapse of alveoli. Then capacity during pregnancy decreases, but volume increases. There is a marked rise in tidal volume and increase in minute ventilation. These are the various parameters of respiratory system which changes according to the requirement of the patient during the pregnancy. Parameters are enumerated as below. Oxygen consumption increases by 20 to 50%. Minute ventilation increases by 50%. Tidal volume may rise up to 40%. Respiratory rate, most of the times it will slightly raise or it remains unchanged. PaO2 may rise up to 10%. PaCO2 may fall up to 15%. Bicarbonate concentration may fall up to 15%, and functional residual capacity might decrease by 20%. Central nervous system. There is a marked rise in the blood flow to the cerebral circulation is seen because of the engorged epidural. Sorry for the disturbance. The central nervous system, there is a marked increase of cerebral blood flow might be seen because of the engorged veins, epidural veins, and vertebral veins. And there is an increased permeability of blood-brain barrier, so the transmission of drugs, proteins will be more during the pregnancy. And there is a increase in threshold to pain during pregnancy, and neurological paresthesias due to the stretching of lateral femoral cutaneous nerve may be seen in pregnancy. Gastrointestinal system. There is a marked decrease in the tone of lower esophageal sphincter is seen during the pregnancy, which results in increased incidence of GARD and acid peptic disease during the pregnancy may be seen. There is a hormone which is secreted by the endothelial cells of the intestines, that is motilin, which results in it basically impacts the motility of the intestines and increases the gastric emptying and movement of food through the intestines during normal individual, but during pregnancy there is a decrease in motilin concentration in the plasma, which results in decreased motility of esophagus and all the gastrointestinal system, and that further results in decreased gastric emptying and decreased acid production, and there might be a vomiting sensation during pregnancy, which results in hyperemesis gravidarum and morning sickness. Hepatobiliary system. Liver is basically displaced upwards because of the enlarged uterus. Hepatic function and blood increase in serum albumin is due to an expanded plasma volume. The free fraction of albumin-bound medication is increased. A 25 to 30% decrease in serum pseudocholinesterase activity is also present at term, but it rarely produces significant prolongation of acid action. Increased cholesterol gallstones may be seen because of the progesterone activity on the hepatobiliary system, which results in the decreased movement of decreased smooth muscle contraction, which results in the stasis of bile, and which further may result in gallstone formation. Genitourinary system. There is a marked increase in the size of the kidney because of the intravascular and interstitial fluid component during pregnancy. There is a rise in GFR, there is an increase in protein excretion and glucose excretion because of the increased permeability of the glomerular membrane. There is increased renin and allogeneic system because of the progesterone activity, and there is a decrease in serum creatinine and burn as they are excreted more in urine. There is a decrease in systemic vascular resistance, which further results in hypertension. Immune system. There are several changes during the pregnancy. Usually, pregnancy is a immune suppressive state where the even in a immune suppression, TLC count increases, neutrophil count increases, baseline IgE levels will raise, function of WBC decreases, and the chemotaxis and adherence of the platelets and all the WBC and other uh, immune components might decrease. Granulation by T helper cells protects the fetus at the maternal interface Usually, the fetus might be detected as a foreign body by the mother endometrium, because of which there might be a chance of lysis of fetus. So this granulation helps in protection of the fetus from at the maternal interface. Body weight composition during pregnancy. There will be approximately 10 to 12 kg weight gain during pregnancy, out of which 1 kg is the gravity uterus, and the 1 kg is approximately amniotic fluid, and 4 kg approximately is the fetus and the placenta. Blood volume and interstitial fluid will be constituting around 2 kgs. Fat and protein gain during pregnancy will approximately 4 kg. Anesthesia implications. First of all, the position of the patient is very, very important. During the supine position, there will be a aorta caval compression, because of which hypertension may be seen. So, while placing the patient, we should place the table at an angle of 15 to 20 degrees, or we should place a wedge below the back so that the position of the patient will be slightly left tilted or right left tilted, so that the compression over the aorta and vena cava will be reduced. And the second point is blood replacement. There is approximately loss of 500 ml blood during normal vaginal delivery, and it will be up to 1 liter during cesarean section. We don't have to transfuse any blood with a loss of 500 ml, as this 500 ml is usually present in the intervillous space, so it will be lost during pregnancy. So there is no need of transfusion if the blood loss is 500 ml or below it. Implications during general anesthesia. There we might face a difficult intubation because of the edema of upper respiratory tract, edema of pharynx, edema of larynx epiglottis, and even nasal mucosa. And apnea tolerance will be reduced during the pregnancy. It is usually 2 to 3 minutes in pregnant lady, whereas in pre-pregnancy state or a normal individual, it will be around 7 to 9 minutes. So, rapid sequence intubation is advisable during pregnancy. Rapid sequencing with acetylcholine or rocuronium is advisable during the pregnancy intubation. IV agents also requires low doses, as the sensitivity of nerve fibers to anesthetic drugs will be increased, so the dose required is reduced during the anesthesia. Even inhalational agents, the dose required will be reduced in case of general anesthesia. While coming to the pseudocholesterase activity, the activity of pseudocholesterase reduces by 20 to 30%. So the relaxants which we are administering during pregnancy will have a prolonged action. So the repetition of drugs and the doses of drugs might be slightly reduced during pregnancy. Spinal anesthesia implications. There might be a difficult spine because of the decreased vertebral space due to lumbar lordosis. And while giving spinal anesthesia, we usually feel the giveaway sensation while passing the dura, but that sensation might be lost during the pregnancy because of the relaxin hormone, which relaxes all the ligaments in pelvis, even in chest cavity and even in spine. There will be marked hypotension, as I've already mentioned. The peripheral sympathetic activity usually balances the pregnancy supine hypotension. If you give spinal anesthesia, then those nerves will be blocked, and which results in further marked hypotension during pregnancy. Even the dose required during for spinal anesthesia during pregnancy decreases because of decreased CSF volume and increased sensitivity, thoracic kyphosis, raised abdominal pressure because of gravity uterus, and more spreading uh, in the lateral portion. Usually, spinal anesthesia will be given in the lateral portion during pregnancy. So the headward spread of anesthetic agent will be more during pregnancy. So more during this position. So the dose required is usually lesser than the normal dose which we administer in normal patients. To quickly summarize the presentation, this is the picture depicting the various systems and their changes during pregnancy. Hormonal changes: increased steroid hormones, increased T3, T4 levels, prolactin, statin, estrogen, progesterone, and beta-HCG. System increased blood volume will be there, increased plasma volume will be there, cardiac output, vascular resistance will be there, blood pressure usually decreases, so dilatation and varicose veins may be, and DVT may be seen during the pregnancy. Respiratory system, there is an increased tidal volume and respiratory rate. Renal, increased blood flow will be there, and increased GFR will be there because of the increased blood flow. Increased sodium retention, water reabsorption will be there because of the action of progesterone on renal. Increased protein excretion and physiological adenophrosis might be seen during pregnancy. Uterus usually it is 100 grams and which might rise to 1 kg during pregnancy, and myometric hypertrophy will be there. In cervix, there is an increased discharge and tropion might be seen. Vagina, hypertrophy of the vagina, vaginal mucosa, and increased discharge, candida, bacteria. Basically, vaginal pH will be reduced. So, the opportunities infections might be seen during pregnancy. Hematological changes, there is an increased production of RBC, there is an increased count of WBC, decreased platelets, hematocrit value will be reduced, clotting factors values will be raised, decreased albumin as the excretion is more. And on skin, there are several changes like linear diagram, melasma, stria gravidarum, spada nevi, and plasma erythroid. To quickly summarize this, we can discuss this in a case scenario where the patient is taken for C-section under general anesthesia. To illustrate how all these changes may affect anesthetic management, imagine performing a general anesthesia for a C-section or C-section. And there are some key points that I would like to summarize. Careful attention to the assessment of the airway and any necessary preparation to deal with a potential difficulty airway in the preoperative period is required. When positioning the patient on the table, remember to use either a left tilt of between 15 to 30 degrees on the table or a wedge under the right button to minimize the aortic caval compression. Venous access often is due to engorgement of veins. Pre-oxygenation is essential and should be with a tight fitting mask for at least 3 minutes and advisable is 5 to 7 minutes. Rapid sequence induction with the application of required pressure is mandatory. Intubation may be difficult, and so adjuncts like a bougie or a stellate be kept available. Once the airway is secure, ventilation should be aimed to keep the PCO2 in the normal range of pregnancy. The lack of volatile anesthetic agents is slightly reduced. There is decreased sensitivity to endogenous and exogenous catecholamines, and if vasopressors are required to maintain adequate blood pressure, the amount needed may be greater. Extubation should be done with the patient awake and on their side to reduce the risk of aspiration of gastric emptying. And these are my references: Miller's anesthesia, Chestnut's obstetric anesthesia, and Morgan's and Michael's. Thank you.
Thank you, everyone. Thank you, Dr. Santosh. And congratulations on your first presentation in Morton Group.
Thank you.
We are now open for discussion on this topic.
Santosh, when you go to PAC, what are the questions you ask for? What are the cases you can actually post better, and which term is good for posting for surgery? Because as anesthesiologist, we know the physiology. We don't know. We should learn the physiology. Everybody should know. At the same time, which time of the pregnancy good for surgery compared to other terms?
Sir, more than 36 weeks is good for pregnancy, sir, as the term is reached and the fetal development will be more.
What are the emergencies you get in pregnancy? Because pregnancy normally they avoid medication and surgeries. Which are the surgeries they need to undergo for surgery without delay?
Sir, the cases in which the cardiovascular compromise is there, fetal distress or maternal distress, and
I'm not talking about Dr. Santosh.
yes, sir.
I'm not talking about cesarean. I'm talking about non pregnancy related surgeries. Other surgeries, what are the things you may come across? Chances are there.
Non-obstetric surgeries in pregnancy.
DVT, sir.
You said DVT.
Sir.
Okay. Then? Any
Sorry,
chance
sir,
of appendicitis?
Sorry, sir, I'm not able.
Any appendicitis?
General surgery case.
Sir, general
Hernias.
appendicitis and even lap cholecystectomy, sir, because of gallstones.
Yeah. And what about trauma? Traumatic pregnancy and trauma?
Sir, blunt trauma, abdomen.
No, not abdomen, anywhere. What I'm telling is any pregnant patients, they need to undergo for surgery, which requires anesthesia. And that is the reason why we should know about the entire physiology of pregnancy. See, routine pregnancy anesthesia, that's for cesarean, that's for delivery, that's for painless labor, and that is for any sudden IUD. Those kind of things are one aspect. Another aspect of important for anesthesiologist is to know entire physiology, because you need to take care of physiology when they are undergoing whichever week they are. You have to give anesthesia, provide anesthesia for better outcomes, taking care of both mother and fetus. That is our goal. And avoiding the abortions, avoiding the complications, taking care of safety of the mother and child. So that's the reason we should know more about physiology of all pregnancy, and every drugs what is going to interact with which drugs are going to cross placenta, which drugs are not going to placenta, which drugs are will have effect, and the position of the pregnancy patient on the table, and how to monitor the pregnant patient, the compression and as well as things, and what are the things monitoring required. These are the important aspects which anesthesiologists know, other than the anatomy of variation of the airway and drug reactions, and regularly
Roger.
what drugs they are taking. Yeah, somebody is telling. Sorry. Please go ahead.
Sorry, sir, my net got disconnected, sir. As of now, I just rejoined the system.
ఓకే నేను చెప్పింది ఏం లేదు. నేను ఏంటంటే అనస్థిషియాలజిస్ట్ మామూలుగా ఎయిర్వే ఒక్కటే కాకుండా, అంటే పర్టికులర్ గా ప్రెగ్నెన్సీ రిలేటెడ్ ఎయిర్ కాకుండా ఎవ్రీ టైమ్ ఆఫ్ ఫిజియాలజీ అవసరం. ఎందుకంటే బికాస్ ఏ టర్మ్ ఆఫ్ వీక్ లో మనకు షీమే అండర్గో ఫర్ ఎమర్జెన్సీ సర్జరీస్ మనకు తెలియదు. డ్రగ్ ఇంటరాక్షన్స్ అండ్ ద ఫిజియాలజీ ఇస్ మోర్ ఇంపార్టెంట్, బికాస్ we have to prevent the abortion. We have to take care of both mother and fetus problems, because of the which drugs are going to cross placenta or not going to cross placenta. These are all important. That is the reason we should know more about entire physiology, so that we can have a better physiology control of the pregnant patient. Thank you.
Thanks.
Hello, Santosh. Hello. Santosh, are you there?
Madam is there, madam.
Not responding.
Not, madam.
Hello, good morning. Hello.
Santosh,
Good morning, ma'am.
morning. Didn't you resound? Santosh, when you say about the systems, particularly respiratory, cardiovascular, ఇంకా కొంచెం depth లో చెప్పాలి physiological changes.
Okay, ma'am.
What happens with your FRC? What happens with your closing volumes? What happens as the pregnancy advances? What happens in the respiratory changes? Why they get breathless? ఇవన్నీ కూడా చెప్పాలి. Not just respiratory rate and tidal volume. What happens with the end tidal CO2? Where you think it's significant? మామూలుగా అయితే 40 అంటే PCO2, you may think it's normal, but in pregnancy it's little high.
Okay.
Because what happens in pregnancy, as the minute ventilation goes up, end tidal CO2 will go down. So 40 may be bit high for them. So అలాగా respiratory system లో కొంచెం depth లో in detail you should know. then only you know what's happening when you give GA. Okay, 40, 45 vastundi, I'm fine అనుకోకూడదు. That's a bit more. That's respiratory acidosis for them.
Okay.
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 అలాగే కార్డియోవాస్కులర్ లో ప్రీలోడ్ ఆఫ్టర్ లోడ్స్ బ్లడ్ ప్రెషర్ ఫస్ట్ ట్రైమిస్టర్ లో ఎలా ఉంటది, సెకండ్ ట్రైమిస్టర్ లో చేంజెస్ ఏం రావచ్చు, థర్డ్ ట్రైమిస్టర్ లో కొన్నిసార్లు సిస్టోలిక్ మే గో అప్ లిటిల్ బిట్ బట్ నార్మల్లీ, బట్ డయాస్టోలిక్ విల్ స్టే ద సేమ్ ఆర్ గో డౌన్ లిటిల్ బిట్. బట్ యూ హ్యావ్ టు సీ ఏ నంబర్ వాట్ నంబర్ కంటే ఎక్కువ ఉంటే యూ వుడ్ థింక్ they have little high blood pressure, you have to keep an eye on them. అలాంటివి కొంచెం డీటెయిల్ గా తెలవాలి.
Okay.
సో ఫిజియోలాజికల్ చేంజెస్ లో మెయిన్ సిస్టమ్స్ లో యూ నీడ్ టు నో ఇన్ డెప్త్. దెన్ వెన్ యూ డూ ద అనస్థీసియా ఫర్ దెమ్ యూ హ్యావ్ ఎన్ ఐడియా వాట్ వీ షుడ్ మెయింటైన్ అనేది.
ఇంకోటి ఏంటంటే కార్డియాక్ పేషెంట్ అయితే కన్నా ఏంటి అదొకటి ఇంపార్టెంట్.
Okay. Yeah, this is your first class అంటున్నారు. Good, you did well. But next time నుండి నువ్వు చేసినప్పుడు కొంచెం సీనియర్ తో ఇంకా యాడెడ్ పాయింట్స్ ఎక్కడ స్ట్రెస్ చేయాలి అనేది కొంచెం తెలుసుకుని చేస్తే ఇట్ విల్ బి ఈవెన్ బెటర్. గుడ్. థ్యాంక్ యూ. బై.
థ్యాంక్ యూ. థ్యాంక్ యూ.
హలో చెప్పినట్టు సారీ ఐఎమ్ చందన. మోహన్ సార్ చెప్పినట్టు ఫంక్షన్స్ ఆఫ్ ప్లసెంటా అండ్ వాట్ డ్రగ్స్ పాస్ త్రూ వాట్ ఆర్ ద అది ఇంక్లూడ్ చెయ్యాలి వెన్ యు ఆర్ టెలింగ్ అబౌట్ physiological changes of pregnancy. At the same time, you can a bit touch about fetal circulation, fetal maternal circulation. అది కూడా కొంచెం ఇంక్లూడ్ చేస్తే బాగుంటుంది. At the same time, నువ్వు ప్రతి ఫిజియాలజీ చెప్పాక వాట్ ఆర్ ద అనస్థెటిక్ ఇంప్లికేషన్స్ అన్నది నువ్వు సెపరేట్ గా పెట్టి రాసి చెప్తే బాగుంటుంది. అంటే హౌ ఈస్ దట్ ఫిజియోలాజికల్ చేంజెస్ ఎఫెక్టింగ్ యువర్ అనస్థీషియా వర్కప్ and how is it changing your mode of action or your plan of treatment anamata. So and what effects will it have? అలాగే డ్రగ్స్ ఏమన్నా చెప్పినప్పుడు దాని ఇన్ డెప్త్ ఈచ్ డ్రగ్ ఎట్లాగా ఫంక్షన్ అవుతుంది, దాని మెటబాలిజం ఏంటి, దాని డోసెస్, అంటే బికాజ్ ఇంకా ఇది స్టార్టింగ్ కాబట్టి నువ్వు స్లోగా ఫ్రమ్ బిలోయే చెప్పడం బెటర్. లైక్ వాట్ ఐ మీన్ టు సే ఇస్ ఇన్ డీటెయిల్ ఆఫ్ ద డ్రగ్. వీలైనంత ఇన్హలేషనల్ డ్రగ్స్ కానీ, ఓపియాయిడ్స్ కానీ, ఇండక్షన్ ఏజెంట్స్ కానీ ఫుల్ అవి ఎలా మెటబలైజ్ అవుతాయి, అవి ఎట్లాగా బయటికి వెళ్తాయి, ఎలిమినేట్ అవుతాయి, అవి ఎలా ఎంత డోసెస్ కి తగ్గించవచ్చు, అవన్నీ కూడా చెప్పాలి. ఓకే. అనురాధ మేడం, I think I stopped you in the middle.
Okay.
Sorry.
Congratulations, Dr. Santosh.
Thank
And
you.
In your presentation, you have to add the few points like what is Oxford position and double four effect. What is double four effect in this patient? And the causes of decreased local anesthesia requirement during neuraxial blockage, like reduced buffer capacity, increased progesterone concentration, epidural venous distension. You mentioned about lumbar lordosis and CSF pressure. During labor, it is increased the CSF pressure. Like this, you have to mention 8 or 10 points. And the advantage of regional compared to general, you have to mention the risk of pulmonary aspiration, avoid possibility of failure intubation, and polypharmacy drugs are we can avoid, and awake mother. Like this, you have to mention the 5 points.
Okay.
And difficult intubation also, can't intubate, call for help. So you have maintain, and always think about the rapid sequence in intubation. And the blood loss also, more than 1000 ml, immediately patient vitals, everything will change. That also you have to think that time. And the signs of shock also important. It caval obstruction or aortal obstruction, you have to specify. and decrease albumin levels and increase the free fraction of high protein drugs, bound drugs. So these are the things, few points you have to add in the exam also. Okay.
Okay, understood.
Okay. Thank you.
Thank you.
వెజ్ సైజ్ చెప్పలేదు అనుకుంటా కదా.
లేదు మ్యామ్ సైజ్.
Okay, that you can add one more point. And how do you shift the patient to the OR? Like how do you shift, like whether in supine position or in lateral position? That makes a lot of difference in your presentation, or even you during exam also. I'll
Okay.
shift the patient, keep NBM, and shift the patient in lateral position, like that you should.
Okay.
That
Good.
position we can tell as a Oxford position. That means lateral decrepitous with the upward slope in the thorax. So you can avoid the supine position until start the surgery. That is the definition of Oxford.
Understood.
అసలు సంతోష్, యు ఆర్ వెరీ లక్కీ ఫెలో. యు గాట్ ఆల్ సీనియర్స్ సజెషన్స్.
Thank you, sir.
చందన, అనురాధ, మంజుల, రాణి, నవీన్, నేను, ఇంకా ఏంటి, ఇంకా శ్రీకాంత్, జయరాము, కిరణ్ ఉంటే ఇంకా బాగుంటుంది. వాళ్ళు ముగ్గురు జాయిన్ అవుతారు, వాళ్ళు ముగ్గురు చెప్తే. అండ్ మన శేఖర్ ఎట్లాగ మీ దగ్గర ఉన్నారు అనుకో. బట్ డెఫినెట్లీ వెన్ సంబడి ఈస్ డూయింగ్ లైక్ దిస్, ఎవ్రీబడి విల్ ఎంకరేజ్. If somebody is going back, nobody will encourage. When people are trying to do better, and we push you little more better for better upliftment and better thing.
Thank you,
Very
sir.
nice, very nice of you.
Thank you.
Just you can write all the points, whatever is being told to you. You will excel in your presentation, in your case presentation, in your exam. All
Thank you,
the
ma'am.
points are given now. Just write it in the paper and keep it.
Thank you, ma'am. I have already
Okay,
written
good.
down. Thank you.
Oh, good, good.
నవీన్, రమణ ప్రసాద్ సార్ ఉన్నారు, కిరణ్ గారు ఉన్నారు.
Ramana Prasad sir can give some more exam questions.
How do you manage cardiac arrest in pregnancy?
Sir, as per the BLS guidelines, sir.
Hello?
Hello, sir. Sir.
Huh?
Sir, if the patient is unresponsive and pulse is not palpable and BP is not recordable, we will start CPR according to the ACLS guidelines, sir.
ఆ ACLS గైడ్ లైన్స్ ఏంటి అని అడుగుతున్నాడు సంతోష్.
అంటే ఎలా చేస్తావు నువ్వు? బికాస్ there is no pulse, because venous return is also not there. No, you will push the uterus to one side, at the same time do CPR, give IV fluids. Venous return also is obstructed. No, that point has to be. Okay. Somebody will lift it and shift it to the left side.
Left side, and we will start the compression.
What do you call that surgery name?
Sorry, ma'am.
No pulse, no BP. That time gynecologist also available.
Ma'am.
అంటే ఒక సైడ్ మదర్ ని చూసుకుంటూ ఉండాలి, ఇంకొక సైడ్ ఫీటస్ ని చూసుకోవాలి కదా. అప్పుడు ఏం చేస్తారు? హౌ డు యూ రివైవ్? అదే అడుగుతున్నారు. అండ్ కంప్రెషన్స్ కూడా ఎక్కడ కంప్రెషన్స్ ఇస్తారో మారుతుంది ప్రెగ్నెన్సీలో.
ఒకటి పొజిషన్ మారుతుంది, రెండు కొంచెం హైయర్ ఎండ్ వెళ్తుంది, మూడోది విత్ ఇన్ 4 minutes లో సర్జరీ చేసేయాలి. ఆల్రెడీ ఇట్లా ఇంత ముందు కేర్ బంజారాలో విత్ ఇన్ 4 minutes లో పేషెంట్ చేసే సర్జరీ, సర్వైవ్ అయ్యారు మొత్తం, బేబీ అండ్ మదర్ బోత్.
Sorry, sir, I am not aware of this surgery.
No problem. That's okay. You can learn it.
Thank you, sir.
What is Poisson effect?
Santosh, you don't have to say sorry because you say you don't know. That's okay. What is the, you're a first year student. We are 20, 30 years experienced people. We also don't know many things. You don't have to say sorry. Just say that I don't know. That's all.
I don't know.
Only just write those points and just go through it. Ante.
Okay.
Naveen, moderator. Huh?
Yes, sir.
Anything else? Kiran unnada?
Kiran sir, లేదు sir.
Mana Rajam Kiran.
లేరు సార్ లేరు
లేదు sir, లేదు sir.
And Srikanth?
శ్రీకాంత్ సార్ ఐసీలో ఉన్నాను సార్. ప్రెసెంట్ అయితే మీటింగ్ లో ఎగ్జిట్ అయిపోయింది సార్.
Thank you.
థ్యాంక్ యూ సార్.
Thank you,
Yeah.
Santosh. Thank you,
Thank you.
Naveen.
థ్యాంక్ యూ మ్యామ్.
థ్యాంక్ యూ మ్యామ్.
Chalo. Thank you.
థ్యాంక్ యూ
Thank you,
మ్యామ్.
ma. Bye.
Yeah, I think we can close it, no?
ఎస్
థ్యాంక్ యూ మ్యామ్.